Hello everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Avery Kelly. This week, we are again having a presentation that was given during the Medicine in the Mediterranean conference last January. Today, we have Dr. John Quinn giving his presentation on damage control resuscitation in large-scale combat operations. Dr. Quinn is a former paramedic turned doctor who has been on the front lines of Ukraine since the invasion in 2014. He sits on our CoROM postgraduate faculty and continues to push for evidence-based medicine in austere environments. And now, Dr. John Quinn.
These are some lists of the affiliations in cooperation over the last 11 years or so. Right now, as I said, I do practice emergency medicine at East Surrey, and my boss is in the room, no pressure. I also do a research and lecture at Charles University, First Faculty of Medicine, and you can see the other, I'm an adjunct professor, lecturer here at the College of Remote and Offshore Medicine, or so I'm told. And you can see some of the other affiliations as it relates to Ukraine specifically. So some important key assumptions, and the reason I discuss this, and these are updated from previous presentations from autumn and winter, is that some people don't necessarily have these same assumptions, but these are my research assumptions as it relates to some of the findings and really some of the descriptions of what's happening in large-scale combat operations in Ukraine as it relates to damage control resuscitation. So first and foremost, that Ukraine has eclipsed NATO and partner counterinsurgency experience. So what they're doing in the pre-hospital space is more than what we have done in a large-scale combat operation, and we need to really capture those observations and those lessons, because what they're doing is far beyond a lot of the issues of what we've seen in the pre-hospital environment, whether you're in a military environment or a civilian environment. Doesn't necessarily mean that they're doing it excellently and well. It does mean that they are doing it to scale in some form or matter. Also, that grassroots ground up versus top down models of support and enhancement and assistance, these are really challenged. What that means is, do you go out to units in the far forward environment and support them and see if you can generate change, or do you go all the way to the senior command and say, hey, this is a really great idea, maybe you should try to do this. Both of those options, both of those methodologies have been challenged. Over the last 11 years, some things have worked very well, other things have simply fallen flat. There's been a lot of movement over the last probably 3 or 4 months. Lessons that are not shared have indeed been lost. These are not entirely forgotten, and as it relates to damage control resuscitation, we're going to see some of the things that they've done based on input from partner forces such as NATO and other NATO members. Some things have worked very well, and some things have actually led to an increase in morbidity and mortality. We have to capture that so that we really understand what to do going forward in order to promote best practices. Large-scale combat operations require an entirely different approach for medical planning and logistics. If you want to be able to provide blood products and really provide far-forward damage control resuscitation, it's going to require a completely new revamp of your whole C2, your whole logistical approach of what you're doing. And I think it's very important to understand that. Good medicine does equal force lethality. And you're like, dude, John, calm down. Force lethality, what does that mean? Hey, this is, if you're a part of NATO or NATO partner forces, we want to be able to have medical readiness. That medical readiness means what the military and security forces are going to do is going to work well and obviously keep everyone else safe and hopefully bring as many people home as possible. So some simple objectives. Really, it's about updates of the entire 2024, as well as about 10 days ago, I just got back. It really highlights some of the things that are working, describe some of the things that may need some support, hopefully for the purposes of reducing duplication, as well as for enhancing engagement. This morning I discussed a lot about global health engagement, and really we need to reduce that duplication of effort. We need to increase enhancement and engagement with partner forces, and just kind of discuss some of the basics about damage control resuscitation. Last night, our colleague, Sean Keenan, was discussing damage control resuscitation, DCR, also within the Thor paradigm, as well as others. It's also called RDCR, remote damage control resuscitation, when you're actually in a very far forward environment. And also touch on a little bit about training and capacity building with partner forces. This map, this is a picture taken, you can plug it into here. This is ISW, Institute for a Study of War. some really updated details. This is from 2024, going in and out, in and out. The reason I show you this, as well as more recently, 12 very specific clinical sites just from January of this year. The reason I say this is because it's not a homogeneous zone. And what that means is there's 1,600 to 2,000 kilometers of a forward line of troops or contact line, depending on how you actually describe it. Now, open source information, 800,000 people are in uniform in Ukraine, including volunteers. Anywhere between 200,000, 200,000 plus, whatever that means, this is published information from the Ministry of Defense for Ukraine, are physically on the line at any given time. So that is a massive disparity of what you may get at one location or the other. So you may see a photo, it's like, wow, that's pretty slick location. They have a whole lot of capacity and capability there. And I don't see any patients. It looks like it's fine. That may be one of 150 different specific locations that are serving a Role 1 or Role 2. And you may go 30 or 40 kilometers in any direction and have an entirely different experience. Because of some of the challenges with command and control at a very high level as well as at a mid-level, it's very difficult to plug the resources into where you need to go with your patient. Because of the way things are financed with a partially volunteered force, you may not have access to that. There may be ambulances that you're technically not allowed to use. It's completely against the paradigm of what most of us may be used to. What are you talking about? There's reciprocity, we work, we have mutual aid agreements, and an ambulance is an ambulance. You have a sick patient, we'll sort that out. You call for mutual aid and we'll support. That is not necessarily the experience across the entire line of contact. So what you see and what you may have already read may not actually be reproducible in other areas across the line. I do encourage you to go back to this paper. This is almost 2 years old now from being published, really looking at some of the very specific observations. So as I mentioned this morning, NATO gets a bit tricky when it comes to terminology. They have a very specific lessons learned process and methodology. This paper is really about observations. It's published, lessons learned, trying to be fancy, but it turns out these are really more of observations as it relates to what took place in really the first 8 months of the invasion. Also, it's important about lexicon. A lot of comments about what different abbreviations mean and different types of terminology and what different words mean. And I think it's kind of important. We're not going to walk through all of the details of what the difference between a casualty collection point or a stabilization point, Role 1 enhanced and Role 1 minus, sometimes it's referred to as, and you go down the different echelons of care. There are NATO standardized agreements. And these NATO standardized agreements spell out what you need to have available to be considered one of those echelons of care. And that is to promote interoperability, so that if you're coming from completely outer space and you say, well, hold on, we're coming from a different planet over here, how are we going to engage? How am I going to understand? On the map it says Role 1. What does that mean? Well, technically there is a standard for that. Flush all of that down the toilet when you enter into Ukraine, because the terminology does not necessarily synchronize across the mode. Now we're trying to encourage lexicon allocation and really try to get some sort of synchronization of what that standard means. But it is very important to understand that, A, when you're reading about the literature in Ukraine, but also even for this presentation, I think it's very important to understand there's a lot of spread, and it doesn't necessarily fit with the standard you may have trained with, you may have learned, or you may be reading about right now. Also, that relates not only to echelons of care, but also modalities like casualty evacuation versus medical evacuation. These are the CASEVAC and MEDEVAC abbreviations here. Also see Bernie, commented a few times, but I do want to just say it's chemical, biological, radiological, nuclear, and explosive events. Raise your hand if you think there's C. Bernie activities taking place in Ukraine for the last 2.5 years. Good. All right. Hopefully I'll convince you that everyone will raise their hand at some point by the end of the presentation. Additionally, really understanding the paradigm of tactical combat casualty care, how it starts at point of injury with self-aid, buddy aid. I think this is very important, as well as, we discussed several months now, really, the difference about how many hours it'll take, how many days it'll take to actually get medical evacuation. There's also an abbreviation that I'll show you on 3 different slides about REBOA, resuscitative endovascular balloon occlusion of the aorta, also called retrograde endovascular balloon occlusion of the aorta. It's pretty fancy pants stuff. Someone's bleeding out, and you can actually put a wire into their aorta and blow up a balloon to stop the bleeding. It's very difficult. It's also very challenging in a damage control resuscitation paradigm to be able to do it in a timely manner and be able to have the entire evacuation chain to sort everything out downstream, but it is something that is actually happening in Ukraine quite a bit. Burn care is significantly challenged. And I put a phrase up here, is anyone here a doctor? And what I mean is the clinical governance associated with calling yourself a doctor, a nurse, a medic, a combat medic, a paramedic. Most people in this room have a very clear understanding what that scope of practice may be, what that clinical governance is. A few countries are a little bit different, it's true, but you kind of have an idea. You have a clear understanding. Well, in Ukraine, throw all that out the window because everyone's a combat medic. A lot of people are paramedics. A lot of people are doctors. They say, oh, that's awesome. You're a doctor. This is brilliant. Where did you do your training? I did 2 weeks training in the church parking lot in Poland. And he said, oh, okay, all right. Good to know. All right. And if you really dig through that and try to understand the clinical governance, these are some of the challenging aspects as it relates to terminology being used. Also, telemedicine. Raise your hand. We spoke about telemedicine earlier today. Raise your hand if you practice telemedicine, if you engage with telemedicine, whether you're a sender or a receiver. All right, it's a game changer. It's an absolute game changer. And when you add things like Signal and WhatsApp and Telegram, it really increases the reach of clinical decision making. And this is something that has been used in Ukraine since 2014 to some level. However, now, as we take a lot of, hey, look, if you were a really good healthcare provider in Ukraine, you're either dead or promoted right now. It is 2025. You are dead or promoted. And so you have a lot of non-providers providing care. That is very challenging. And so having access to telemedicine and good practice telemedicine, in representing College of Remote and Offshore Medicine in December, I kind of walked through a little bit about how telemedicine, we were able to really push the boundaries with some of that training and take some providers and non-providers and put them through a pace where they can really lean on telemedicine practice. And it's relatively low tech as long as you have access to Starlink. So I showed this last year, and the reason I'm showing this now is because we have a forward line of troops. That's the FLOT, that's the contact line, if you will. It's nice and pretty here. It's obviously not in reality. You can go forward of that line, you can go backwards of that line. It's entirely different in a field versus an urban setting. It's literally impossible to know where that line is. The closer you get to it, it's very challenging to understand it. There are challenges and difficulties with casualty evacuation from all aspects of that line. There's significant challenges with getting to a healthcare professional. There's significant challenges with self-aid and buddy aid to this very day. Try to train 800,000 people that were not trained 2 years ago in something that may take several weeks, if not multiple iterations of several weeks. By the way, you've got 5 weeks and you have to learn how to use a myriad, an absolute smorgasbord of weapon systems. Oh, and by the way, we're going to take 4.5 hours to do the medical bit, right? So it's very difficult to do that for self-aid, buddy aid. And then being able to get you to damage control resuscitation and damage control surgery with, I have the cool little blood insignia there. That's that's the bread and butter of damage control resuscitation. If it's a part of the whole line of self-aid, buddy aid, tactical combat casualty care, the march, and get you that blood in that order, right? We can't take out of that order. But this is something that is completely thrown away and destroyed with the use of fiber optic drones. Absolutely, you are all targets. We are all targets. You cannot move from that point of injury to roll 1. It is near impossible to get from that point of injury to a roll 2 because of fiber optic drones. Normal drones, horrible, terrible, yes. Fiber optic drones can zip through and make any sort of countermeasure that you have. They will wait. They'll say, oh, awesome, we got a casualty. Let's go and sit and wait for that medevac, casevac to go and get that casualty, and we'll be able to get 3 guys, not 1. And it is happening to such a point where a lot of roll 1s don't have the patient volume anymore because they can't physically get there. You can't get your casualty there. So that 5-day problem, we used to have a 5-day problem because you're in this gray zone. You find yourself in the zero line. The zero line is a fancy way of saying the FLOT, and you may be in -1 because things moved in the last 4.5 hours, and now you really can't get out. But with this, with the fiber optics, as well as other drone and really healthcare under attack, this is really, really limiting that patient flow. So this is a fancy roll 1 enhanced. As I've said previously, this is a blood container. There's no blood inside of it because they didn't have access to enough blood product. They had no universal donor blood. They did not have enough adequate use of blood. They did have Reboa at this location. It looks pretty fancy, right? You're underground. So grads and artillery, okay, you're actually relatively safe. They got the cool gray stuff up, which is actually at almost all of the underground roles, roll 1 and roll 2s right now. They had a decent amount of heating, air conditioning, etc. You may go to the blood bank in a specific location and be able to have access to power. Power goes out all the time. You don't really have a whole lot of power. Water is always a problem. And you can actually go to the blood bank. They're taking blood, they're refrigerating blood, they're getting some blood out to some locations. It's absolutely amazing. You may go, this is from 10 days ago, you may go to a super fancy pants place that has roll 2 capabilities. You can see Reboa right here, off the shelf. I said, show it to me. Am I allowed to take a picture of it? Yep, you can take a picture of it, good. You've got blood, you have 4 different refrigerators. So if you have a QRF that's going to go and pick up that blood and be able to push forward with it, there's 4 of them. These are the C-Safe. I have another picture of the C-Safe. Be able to hold 40 units of blood, and you can push forward with that. And it's just sitting on standby. If you don't use that blood, you can waste that blood. They send it back to their blood resource area, and they get more. That's amazing. This is an amazing logistical supply. And you may also get access to damage control surgery. You have access to ultrasound. You have access to surgeons, anesthesiologists, advanced drugs. Absolutely brilliant. You may have access to an X-ray machine. You may have, this is a pretty fancy pants system. It's actually a very small source for X-ray. You may have access to blood work. So the testing of blood is super important. Being able to understand what your hemoglobin is, being able to understand your lactate, really having like lactate-driven resuscitation is something that's absolutely necessary. So when you have an injury like this from the weapon systems, it's absolutely horrendous. I just want to comment a little bit about the different weapon systems based on drones. So anecdotally, when you're in a truck, when you're in a different type of position, a lot of head and neck and a lot of upper limb injuries based on the drones and how they're attacking. Now that's different than previously with a lot of Grad rocket and artillery fire, where it's actually a lot of lower limbs because you're actually relatively protected on the upper part, but you're not so protected below. So that is a bit of a difference with some of the wounding patterns based on weapon systems deployed. You may also have access to, so this is a fancy C-Safe. It's a really cool, slick unit that can hold a whole lot of blood for a long amount of time. And Belmont Systems be able to do huge blood warming in a kind of a hospital environment. And then some blood kits that actually have, inside of these are all donated, they have the ability to actually test for infectious disease like hepatitis and HIV. You may also have this. This is a different type of place that was bombed almost immediately because we want to bomb all, this is, obviously you can see fancy windows, right? So bad guys want to go and bomb all the healthcare facilities, so it's a priority target. Now, you may have a casualty evacuation, and this may count as your roll 1. This is blood in the back of a truck, and that's it. That's your roll 1. And whether or not you get to a roll 2, that depends on the rest of the logistics, how bad you are, and what the road looks like. You may also have access to something like this. Now, our colleagues from Tactical Medicine North will hopefully be here later today or tomorrow morning. This is from one of their locations that was acting up as a roll 1. And then to the right, for a lot of the northern operations outside of country, you can see this is basically a home that's been converted. This it doesn't project well, I apologize. It's under red light, strict light discipline. This is also where you can keep blood in a ditch and still be able to provide blood far forward. But this may be where you're getting blood, not that cool, fancy, silver-lined room, etc. Now, a big challenge that was really from September until about the first week of December was this area of Ukraine. I know it's kind of difficult if you're not used to it, the geography of Ukraine. This is the whole Crimean bit right down here. And then you can see Kherson and Mykolaiv. And you can see the green part, which is like relatively liberated area. So that's all Ukrainian controlled. And then you can see all the red part with all these little red dots. These are all the bad guy positions. Now there's a river that goes right through. It's not really a river, it's actually an estuary that zips through. I'm not sure if you can see it well on this projection. So the water, they don't use north and south, they use left and right. Don't know why, but so it's very challenging this is all water. It's a bit of an estuary. In some instances, it's about 50 meters across, and sometimes it's like 100 meters across. And it's a very challenging place to do medical evacuation. Raise your hand if you've done maritime evacuation or casualty evacuation. I mean, super challenging environment. It is very cold. It is always wet. Doesn't matter. Middle of August, it's cold somehow, and it's a very challenging environment to be able to do, consider medical evacuation and casualty evacuation. For some reason, the colors are weird on this. I don't know why. It looks much better on the screen. So the U.S. Department of Defense has donated these really super slick boats. You can see the reference points just here. Not the one on the left. This is a drone from that Ukraine has made organically. So the aerial drones took out the boats in about 11 days. Several hundreds of thousands, millions of dollars worth of equipment and training, etc., gone. So they started to use other boats that were available. It's a huge estuary. There's a lot of boats that were there 10 years ago. People go fishing there. It's a normal place. All those boats were destroyed. So you're trying to get more units to that area to be able to do what they're going to do, as well as try to get medical evacuation out, and every single one of them are getting hit. You're going 35 miles an hour maximum, and a drone has a beautiful sight picture of nothing but water and one moving thing. So whether it's night or day, it doesn't matter. So they made this little drone, and they can put a patient in here, they can put a casualty in here, as well as equipment and resupply, etc., and go back and forth. And trying to get blood in that is a worthwhile cause. However, the enemy drones can take out boats despite going like this. Now, can you imagine trying to go 100 meters, 150 meters, going left and right in a very sporadic sort of way to try to avoid all of the drone activity with a patient? Very challenging environment. And so after all of those boats were all destroyed, they went back down to the kind of fishing boat version, and it's a absolutely miserable environment. So shift gears to some of the other aspects of DCR, of damage control resuscitation. This is kind of an awkward picture. This is taken at one of those fancy Roll 1 enhanced, and actually this is from a Roll 2 minus 10 days ago. This is a Moves SLC device. This is a Thornhill device. The reason they paid me to go, well, they paid for my train ticket, is because I took one of these. This is a little device that you can plug into that machine, and you can make these little, oh yeah, I have a cool little arrow. So you take that little device. It's a single use. It's kind of a pain in the butt, but it worked. And you plug it in there, and you do this little code. And we had to call all these people and do all this stuff. It was very challenging. But once you put that code, then inside that machine, you can use these indirect hemoglobin sensors. So without having to have a testing kit of any kind, you know that cool testing kit that I showed you, you can actually put it on a finger, just like your pulse oximetry, and you have indirect hemoglobin measurement. It's plus minus 5. It's not, it's some super accurate thing, but hey, when it comes to triage decision making, you can say, well, listen, I've got 8 very unwell patients. They're all bleeding. I don't know if any of them are active. I don't know what the HB drop is, but now you do, because you can say, okay, well, just take this probe and put it on their finger and see who's got the lowest hemoglobin. So it will be very helpful with clinical decision making. But anyway, that was one of the biggest pushes forward. There's 235 of those machines in country. Some of them have been destroyed, but there's the ability to have this very far forward and support with decision making of indirect hemoglobin, I think is worthwhile. I asked this morning, who's got deployed medicine? You all better have downloaded it by now. So the reason I show this is twofold. Number one, because I think, spread the good gospel truth of deployed medicine, and I can leave it up there for a few moments. And number two is that it's mirrored website. Partially mirrored website is in Ukrainian, tccc.org.ua, because a lot of the training that Eric and I and others have done really is taken directly from those clinical practice guidelines that Dr. John Quinn also described yesterday, and really be able to push that into the Ukrainian language so that best practices are carried out in the pre-hospital space. So kind of take a little bit of a deeper dive with that. You can see these are just screenshots of the tccc.org.ua. And you can see there's a lot of abbreviations, and I appreciate and I apologize for some of them now that I look at this slide specifically. But damage control resuscitation and prolonged field care, prolonged casualty care, really looking at what is available in the Ukrainian language. We were training in December, we were training in May and June, and we were training again in September, specifically with Ukrainian language and English language prolonged casualty care guidelines available for the training audience with translation already achieved. Now, there's also a significant push within the Ukraine Ministry of Defense to have the combat medic corpsman, this is what the CMC is, as well as the combat practice paramedic practice. Who's familiar? Who's like a deployed medicine, like hardcore? So those two courses are now going to be the standard for the Ministry of Defense for Ukraine. And the CMC is a fancy 2-week course of TCCC on steroids, and the CPP is really an intense deep dive on the trauma side, not the medical side, but it's a deep dive on being able to have paramedic practice standards within the emergency medicine paradigm. There's also a lot of new prolonged casualty care guidelines, in-route casualty care. There's radio frequency clinical practice guidelines that were published just in July and August. And I think there's, as we heard last night, there's going to be more coming out as well. I think it's really, really important to use this resource and also to promote this with our partner forces. Now, I also put down here the asset course. The reason I put this down here is because everywhere I went, all 12 clinical sites in late December, January, all of them were screaming out for advanced surgical care within trauma. And the asset course is one option of this, and you'll see other slides of different options, different surgical and parasurgical support. But really, this is something that we really have to have a little bit more focus on as it relates to support with partner forces and global health engagement. So here's training this past summer. We were doing, here we have the clinical practice guidelines. These are in English just because it was easier for me. And then the ones on the bottom, this is just some of the actual training material. And then this is one of the expert instructors. We did a train the trainer program and a damage control resuscitation Ukraine. Damage control resuscitation for Ukraine. We did a course, train the trainer course. And this is one of the trainers. This is about ketamine drip. And really, teach the clinical practice guidelines. And they raise their hand and they say, well, we're not allowed to do that yet. Well, that's okay. You can at least learn how to do it, and we're going to get you that clinical governance on the back end, more global health engagement activities. So here's more of the training that took place. Here's actually a MOVES SLC device. The reason being is that the unit that we were training was using this in the far forward space, mostly at a Role 1 environment. The whole reason why this unit is kind of old. It's not that fancy. I don't know, raise your hand if you ever used the MOVES SLC device, or if you have any idea what I'm talking about. Yeah, this guy had to train on it for 2 weeks. It's a bit of an old system, but you can monitor, you can ventilate, you can suction, there's an oxygen concentrator, and you have a decent amount of functionality, kind of all in this sort of ruggedized thing. Until something much better comes along, it's a pretty good thing to have, especially when you're doing damage control surgery very far forward. And the rate-limiting step is the critical care transport after that surgery. So if you have something like this, or an equivalent, or if you want to have 2 or 3 machines, have 2 or 3 machines, you can then get off the X and get moving to a higher echelon of care. And that's really that was the problem. How do we move them in a critical care vehicle of opportunity? I don't know. Well, this is one option. This is one piece of that puzzle anyway. And then, doing some REBOA training. Did we train REBOA in Ukraine? Absolutely not. We trained what REBOA is, how it works, what the physiology is, and what the concept is so that you can manage it in case you see it, or in case someone comes that does want to do REBOA, you can at least support that process. So cool, fancy arrow with the indirect hemoglobin measurement. I know you can't read this that well. This is about clinical governance. Specifically, this is from GRM, Global Response Medicine. It's also posted on the MOZ, the Ministry of Health website, specifically looking at different levels of providers, what you can do. The reason I show you this is because clinical governance is really important. It's super boring, don't get me wrong, but it's really important of what you do. I started as a paramedic. I know exactly what I can do as a paramedic. I say, okay, this is what my SOPs are. I don't go outside the SOPs. I stay within that paradigm. And we don't have that in Ukraine clinically. So that's a challenge. That's a very difficult aspect. Well, what can you do? Well, I've had a 2-week course in Eastern Poland in a church parking lot. What can I do? Well, technically you can't do anything, but no one else can do anything and no one else is there. So where do we fit you in? And so one of the aspects, especially as it relates to damage control, resuscitation, and blood, was the UTCC blood course, the Ukrainian transplantation Coordination Center. And what they did was they sat down and they said, okay, we're gonna give you this course for 4 days. Tactical Medicine North, who hopefully will be here tomorrow, actually are approved provider for this. They are here. Excellent, excellent. So good news. So they'll be able to also discuss this in more detail. But if you have a registration, so there's 11 NAEMT, National Association of Emergency Medical Technician centers in Ukraine. If you go and do one of their TCCC courses, due to the nature of a very convoluted process, you can have a TCCC certificate, little card. That card has a number. You can then use that number. You're now a registered provider, by the way, if you do one of those courses and you pass the exam. You're a registered provider, and you can go do the UTCC course. If you complete that course, you've passed that course, you can then, in the pre-hospital space, you can transfuse blood. So why do I show you all of that? Well, it's because of the NAEMT stuff. And you can see here, this is right off of the NAEMT website. This is not fancy information. Roughly 11 centers, sometimes they lose their registration, sometimes a new one comes on. There's really a heightened focus on tourniquet conversion and replacement. There was a huge problem with this. Dr. Sean spoke about this last night as well. Huge issue with tourniquets being applied and really not being a part of a evacuation chain. So no one being able to assess it, no one with any level of training being able to assess it to see about tourniquet conversion or replacement. There's also a bit of a focus on TCCC Stop the Bleed, mostly in schools, high schools, etc. So why do I say this? Because the issue with tourniquets, massive issue with tourniquets. You can see here, co-author from the first paper. I just visited him last week. One of our trauma surgeons and colleagues showing about some injuries and wounds where you don't need a tourniquet, and tourniquets are applied. It's completely understood. Care under fire, apply the tourniquet. There's blood everywhere. I have no idea. Is that yours, his, mine, whatever. You have to have, in a very timely fashion, in keeping with TCCC standards and protocols, you have to be able to assess that and say, do you actually need that? Can we convert it, or can we take it off entirely? It wasn't even your blood whatsoever. That's not happening, and that has not happened, so we have a lot of amputations, unfortunately. And you can see here on the left a similar, almost no injury of any kind, but a very, very high and tight tourniquet. I also want to talk about Mike Mioli. He is a champion for NAEMT in Ukraine. He unfortunately passed away in November. He's done a whole lot with bringing NAEMT to Ukraine, really raising and pushing the standards and really being a champion for pre-hospital medicine. So he's, I really want to, this presentation should be really, devoted to him and his practice in the pre-hospital space. Yeah. All right. So with that, there's also quite a bit more with transfusion and what's happening over the last 6 months. Who's familiar with low titer whole blood? A lot of people, hopefully, right? It's a fancy way of saying, two hands, awesome. It's a fancy way of saying it's O positive blood, but it's below a certain titer. 256 is one fancy way. And you can actually transfuse. There's a whole paradigm of pre-hospital transfusion associated with low titer whole blood, and a lot of you who work in remote areas probably understand it much more than I do. Having said that, it can increase the amount of blood that you have to provide. So I think it's a worthwhile adventure. So we tried it 2 years ago and they said no, and we tried it a year ago and they said no, and finally we got a bit of a green light. So we're now in the process of trying to link all the hands together and be able to pull low titer whole blood in country. It's actually not as hard as it sounds to check it, to check the titer, and due to the nature of the Ministry of Health being a socialized healthcare system, they actually know the titers already of almost every oblast, every state or county. They already have an understanding about their donors, which is pretty intense information. There's an absolute dearth of universal donor blood. There has been offered by the European Union and NATO, and that is a challenging conversation, to say the absolute least. There's also a specific focus on being able to get more than 550 people trained in this UTCC course. There's 800,000 troops. There's 200,000 people on the line. 550 of them have received clinical governance as a provider, non-provider, provider/non-provider, to be able to provide blood. Like, do the math, guys, right? 200,000. 5 minutes, thank you. So I want to kind of zip through this. Are they doing Alden cards? Yes. Are they doing Alden cards? No. It's 1,000 kilometers a line. Every place is a little bit different. Some soldiers, some warfighters have put a tattoo of their blood type on. Some soldiers have it on, actually most soldiers have their blood type on the little patch that is on Velcro. When you have a non-provider and you do not have any more universal donor blood, you went through that in the first 12 hours when you were deployed to your stabilization point. You will be there for 5 days. This is how much blood you have. You have a cool C-safe and you got that stuff gone. All that blood is gone. So when you tell to a non-provider and you start having volunteers bring you O positive, bring you A negative, bring you AB positive, etc., they're going to look at that and they're going to transfuse based on that. Who thinks that's a safe and healthy and smart and good serum vigilance by looking at a little thing on someone's chest and giving them blood? I don't think any of you probably think that, but that's happening. So that's a challenge. That's a significant challenge, and obviously it's a training and it's a capability issue as much as anything else. But it's because there's not enough universal donor, and there's not enough low titer O. There's no low titer O. So that is really a supply issue. This is a logistical challenge that we have, and it's leading to very poor clinical outcomes. Also, plasma. Everyone loves plasma in Ukraine. Did I tell you about plasma? Let me tell you more about plasma. Oh, I love the plasma. We got to get that plasma. Does plasma carry oxygen? No. Plasma is great. It's volume, right? Okay, I'm not going to complain about it. But the only reason everyone wants to talk about plasma in Ukraine right now in the pre-hospital space is because there's not enough blood. And you don't have enough access to blood, and the cold chain is an issue. So I can go into a little bit more of a deep dive on that, and I'm happy to. But it's really because there's not enough blood. So when you sit down with the deputy land command, and he said, no, there's no problem. Everything's fine. My friends are not asking me for more blood, and we have plasma out there. It's great. I was like, the only reason we're talking about plasma right now is because you don't have enough blood. Also, walking donor. A lot of you have done walking donor. Most of you are probably experts at walking donor, and that's great. In large-scale combat operations, walking donor is an academic concept. You may have 65 patients in a 24-hour period, all requiring some form of significant resuscitation. Walking donor is not an option when you can't really go up or downstream safely. So if you've got someone that's O negative, you're going to pluck them. If you're a non-provider or you're a very, very junior provider and you find someone that's O negative, you're going to literally pluck them way outside of best practices, absolutely pushing outside of best practices. In those little volunteer kits, those kits that were donated, they have little rapid HIV and hepatitis C tests. You don't do that with the walking donor. That's not happening. Those kits are gone. You're already pushing past the limit. So unfortunately, anecdotally, there is a massive spike in HIV, hepatitis B and C, potentially others. This request came in probably the second week of December to really take a deep dive on this on CDC. All funding was pulled for that about last week. Specifically for CDC infectious disease monitoring capabilities for HIV TB program. They were able to add a Hep B and Hep C component to it. All the funding was pulled last week. We're going to work on alternatives. Also, access to warmers and cold chain, significant issue. Over-transfusion. Wow, I never realized that would happen in the pre-hospital space. You don't have enough blood. Who the heck is over-transfusing? Indeed, they're over-transfusing because there's no C2 and there's very limited communication between echelons of care. Now, the official standard operating procedure had 2 units at a maximum before getting to a Role 1 or Role 2. Some were receiving 5, some of which did not, 5 units, some of which did not require blood transfusion in the first place. Horrible outcomes. I'm happy to share with you a case study. We're thinking about publishing it. I'm not entirely sure. Huge clinical community pushback. I can understand that. If you're in a clinical community and you're finding about people giving blood based on a tattoo or a little thing, or people, over-transfusing, I would be pushing back as well. It comes down to a training issue. This is another paper I encourage all of you to engage with. This really focuses on global health engagement. The reason I show you this is because it's focused on training in global health engagement. In military medicine, you're not allowed to publish more than loads of words. I have 1 minute. So you click on this little thing, and that brings you to 2 different documents. The 2 different documents will bring you to this, and it kind of goes through some of the aspects of best practices for training in the different modalities. Some things that are a persistent issue since 2014 are not only access to prolonged field care and prolonged casualty care and remote damage control damage control resuscitation to include blood, but also burns, having access to surgical airways and adequate access to surgical airways, good solid training with thoracostomies, chest tubes, needle decompression, antibiotics and antimicrobial resistance, adequate access for pain and pain management, regional blocks, Roboa already discussed. I won't go into too much detail on this. We can probably chat about that a little bit tomorrow. Sea Bernie is an absolute issue, and I'm getting a look of death that I'm over time. Also, I encourage all of you to, as I said this morning, to engage with a vigorous warrior exercise. We're able to do a working group for the lessons observed and identified from the Ukraine crisis, and hopefully we'll be able to do this again in 2026. And I'm happy to take all of your questions. One thing I want to say real fast is that there's a Pediatric Disaster Medicine Foundations and Future course in Salzburg, which is really going to be kind of a combination of pediatrics and disaster stuff. I encourage all of you to come and hit this thing on the bottom right. This is a signal group that we can all engage with and chat remote and austere medicine stuff. So thank you very much. Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.